Look at a localized skin infection, the redness, the swelling. That visible inflammation is the host's emergency defense system in action, operating in real time beneath the surface. By definition, acute inflammation is the protective response of living, vascularized tissue. It produces 5 classic clinical signs: redness or rubor, heat or calor, swelling or tumor, pain or dolor, and a loss of normal tissue function. This flowchart breaks down the entire inflammatory response into 4 distinct biological zones. Memorizing the symptoms isn't enough. We need to derive exactly how these 4 zones generate those specific clinical signs. Following injury, arterioles undergo brief vasoconstriction. Within seconds, mediators force sustained vasodilation, flooding capillary beds with blood. This hyperemia drives redness and heat. Next, endothelial cells contract, widening gaps, allowing exudate to escape. This fluid accumulation drives tissue edema, causing visible swelling. This flowchart maps the kallikrein-kinin cascade. Tissue trauma activates factor 12, triggering a chain reaction where kallikrein cleaves high molecular weight kynogenin to liberate bradykinin. Bradykinin stimulates nociceptors, generating pain. ACE enzymes rapidly degrade it. If blocked by ACE inhibitors, bradykinin accumulates, potentially causing severe angioedema. The entire purpose of these vascular and chemical shifts in zones 1 and 2 is to set the stage. They prime the local environment so circulating immune cells can successfully enter the damaged tissue. As fluid leaves the post-capillary venule, the remaining red blood cells concentrate. Blood viscosity increases and flow slows down, a condition called stasis. This loss of momentum pushes circulating white blood cells out of the central flow, marginalizing them against the endothelial lining. This diagram outlines leukocyte adhesion. In stage 2, the leukocyte tumbles, forming weak selectin-mediated bonds. To stop, activated integrins lock onto ICAM1, creating a structural anchor. The leukocyte then squeezes through endothelial gaps via PECHAM1 and migrates along a chemical gradient, following C5a and IL-8. Let's test your recall. Which molecules mediate rolling versus firm adhesion, and what condition occurs if integrins fail? Selectins handle rolling, integrins pair with ICAM1 for adhesion, and a failure here results in leukocyte adhesion deficiency. This multi-step adhesion cascade ensures the required cellular weaponry is safely extracted from the rapid arterial transit system and deployed exactly where it is needed. Neutrophils are the dominant first responders, flooding the site within 6 to 24 hours. Around the 24 to 48-hour mark, monocytes arrive and differentiate into mature, long-lived macrophages to coordinate the cleanup. This chart shows the 3 phases of phagocytosis. First, opsonins like IgG and C3b coat the target for recognition. The cell engulfs the pathogen into a phagosome, which ultimately fuses with a lysosomal granule to form the phagolysosome. Inside that phagolysosome, the oxygen-dependent respiratory burst takes over. The enzyme myeloperoxidase converts hydrogen peroxide and chloride ions into hypochlorous acid, essentially bleach, which rapidly destroys the bacterial cell wall. This diagram outlines tissue resolution, which requires active biological intervention. Macrophages ingest apoptotic neutrophils, a process called efferocytosis, to prevent toxic enzyme spill. Simultaneously, local metabolism produces pro-resolving lipid mediators and anti-inflammatory cytokines like IL-10. Finally, lymphatic capillaries drain excess fluid to restore tissue balance. If these specific active shutdown mechanisms fail, the tissue remains locked in an inflammatory state. The host's own defense system continues to fire, turning a protective short-term response into a chronic disease process. This roadmap visualizes the complete inflammatory sequence. It tracks the reaction from the initial detection of danger in Zone 1, down through the microvascular and cellular cascades, to the active resolution in Zone 4. This table maps the clinical signs directly back to their physiological origins. When you see redness and feel heat, you're observing nitric oxide and prostaglandin-driven vasodilation. When tissue swells, you are witnessing increased vascular permeability, and local pain is the nociceptive result of bradykinin generation. The accumulation of pus marks the massive influx of white blood cells during Zone 3's recruitment cascade. Finally, the complete restoration of tissue function requires the successful execution of efferocytosis and lymphatic drainage in Zone 4. By tracking these physical and chemical reactions sequentially, you move past memorizing a list of symptoms. You can reconstruct exactly how the body recognizes, fights, and ultimately recovers from a localized threat.